Diabetes is a very heterogeneous disease. We hear about type 1 and type 2 diabetes, and we're talking about type 2 diabetes right now, but even type 2 diabetes it's a lot of different types of diabetes, and until we know better, until we understand diabetes better, we're going to have actually several diseases labeled as type 2 diabetes. So that makes it hard. Now, so practically, what do I do? It depends, like everything. So I consider the patient's age, the patient's life expectancy, the patient's socioeconomic status, sometimes cultural issues. I consider their comorbidities. That's a very important one. Their phenotype, the clinical phenotype, very important. I don't treat the same somebody who is lean versus somebody who's overweight or obese, or somebody who is insulin deficient or somebody who is insulin resistant, predominantly. They're costly, but you have to put that into the context of the benefit, and all these things that we hear about, the number needed to treat and number needed to harm and relative risks and all those things. They're all, like it says, relative. It depends who you are treating. So the trials that show this relatively high number needed to treat, which I believe is in the 60s or 70s for about 3 years, to avoid an event, one of the primary endpoints of these studies. It seems high. We generally think about 50 as a number, as a cutoff, to say above 50 is kind of high, below 50 it seems reasonable. It really depends. What population are you talking about? Are you talking about primary prevention, or are you talking about secondary prevention? Are you, how was the study done? And I think to some degree that these drugs had it very hard to show a benefit. And I am actually surprised that they show the benefit, because these patients were already on pretty good intensive therapies with anti-cholesterol agents, statins, antihypertensive agents, other anti-diabetic agents, and lifestyle interventions. All these other things were being done. So every time you add something, it gets a little harder. I would say that if you have somebody on a statin, and you've already doing some benefit to that patient, and you add another statin on top of that, not that I would do this, but you're probably not going to get a whole lot from the second statin. You're going to get mostly just side effects, and the number needed to treat with second statin will be very high, because a lot of the risks that you would have perhaps avoided with it have already been taken care of. So to some degree, this has happened with these drugs, is with many of the diabetes trials, is some of the low-hanging fruit has already been picked by the other therapies, so it's really hard to show further benefit. Still, we have to consider the cost, and the problem, though, is that we don't have good cost-effective analysis out there of the kind that would show us the cost per quality of life gain, those kind of studies. So until then, I think we have to put it into context of the patient, the side effects, the physiology of our patients. There are other things that we consider, and I think there is still a use for them, despite their relatively seemingly high cost retail value. There's another point here too, is that these drugs, besides reducing these cardiovascular endpoints and giving you some advantage in that, also have other effects that are not taken into account when you look at just that raw number needed to treat. The benefits in terms of microvascular disease reduction, eye disease, kidney disease, neuropathy, other things, that is not in that equation. And that's something that other cardiovascular agents do not provide. And so that somehow needs to be taken into consideration as well when we're making a decision.